Stereotactic ablation of liver tumors and metastases. How I do it. Thermal ablation is increasingly used for the treatment of liver tumors and metastases. It has several advantages, such as being a curative yet minimal invasive and tissue-sparing procedure with low complication rates. It is sometimes applicable to inoperable patients, and it can be performed during chemotherapy. Its limitations are large tumor sizes, the proximity of important vasculature or adjacent organs, difficult to reach anatomic locations, the respiratory liver motion, and the often difficult immediate control of the treatment success represent further challenges. To overcome these limitations, stereotactic percutaneous microwave ablation was introduced in our department in 2015 using a highly standardized workflow, high-frequency jet ventilation, and a dedicated team of surgeons and radiologists. Up until today, we performed 529 liver ablations in 358 interventions. Stereotactic laparoscopic microwave ablation is performed alone or in combination with resection or as a rescue treatment when resection cannot be performed. And this is how we do it. Before any intervention, the patient is discussed at our liver tumor board, seen in the outpatient clinic, and informed with the help of a patient brochure about the planned intervention. Percutaneous stereotactic interventions generally take place in the interventional CT suite, where the anesthesia team preps the patient for the general anesthesia with jet ventilation. The patient is placed in a 45-degree left lateral position on a vacuum mattress so that the right upper abdomen and thorax is exposed. The marker position is chosen according to the pre-planned axis direction and marked on the patient with the help of this template. The interventionalist preps the patient and prepares the navigation system. Finally, the navigation arm is attached to the carbon board placed below the patient. This overview shows the complete setup before the intervention begins. The intervention starts with a timeout to introduce team members and to discuss the patient's treatment plan. For the planning scan, the whole team leaves the room. A scanning area, including the patient markers, is selected on the topogram, and a contrast-enhanced scan is acquired. Before the intervention begins, the radiologist checks the images for any new findings. The new CT scans are loaded into the navigation system. In case of invisible lesions, it can be fused with a former MRI. The center of the lesion and the desired entry point on the skin are defined with the help of the navigation system. The planned trajectory is double-checked by a 3D reconstruction view, including the needle view option that helps the user to check the anticipated trajectory. You can nicely see the proximity of the colon and the kidney in respect to the anticipated ablation zone. These images here show a different lesion ablated during a different intervention. The target was chosen, and the yellow line displays the anticipated intercostal trajectory. You can follow the planned needle tract and make sure not to injure the pleura or the intercostal artery. Different views help the user to check the trajectory before inserting the needle. The system also allows to segment the tumor, either by automatic recognition or by adjusting the size of this red circle. The computer then predicts the ablation zone, displayed as a green circle. According to the ablation device used and the power and time of the ablation chosen by the user. Again, the 3D views help to plan the ablation treatment. The navigation arm is then positioned according to the plan made. The user needs to adjust the required angle before navigating the device into the camera field. Once recognized by the camera, he needs to bring the red circle into the center of the target. After fixation of the arm, here shown from a different angle, He has to align the green circle by adjusting these two screws on the navigation device. The navigation system calculates the depth to the target so that the user knows how far the needle has to be inserted. The needle is guided by the device to avoid bending and to increase accuracy. A non-contrast scan is performed to validate the needle position. The original scan in red is fused with a new needle scan in green. Potential changes of the patient's position and the liver can be easily detected with this function and corrected if necessary. Once the needle is placed correctly, ablation is started. During the ablation time, eventual further treatments can be planned on the system. Needle-tracked ablation is routinely performed to avoid tumor seeding. Another contrast scan is performed and fused with the initial planning scan. Here you can see the ablation zone in respect to the segmented tumor. In this case, the ablation zone was smaller than expected. This was most likely due to the so-called heat sink effect of the large vessel next to the lesion. Here you can see the lesion before the planning scan, and now changing slowly to the control scan, the ablation zone becomes visible. To achieve a sufficient margin of 1 cm, a re-ablation was performed just medial of the vessel. The incision requires no wound closure and is treated by a sterile wound dressing. Laparoscopic stereotactic ablations are performed in the operating room as standalone procedures or in combination with liver resections. For lesions located in the liver dome or the right lateral liver segments, patients are placed in French position with a semi-left lateral decubitus and the right arm placed on an arm board over the chest. This allows a rotation during surgery and a transthoracic approach. The monitors of the navigation system and the camera for the optical tracking are placed at the patient's head. After the preparation of all instruments required for the optical tracking, the regular laparoscopy begins. The reconstructed pre-op CT scan is loaded in the navigation system and shows the tumors in the liver. The larger lesion will be resected, the small lesion will be ablated. For image fusion to the patient, 4 points are defined on the 3D image, which will later be acquired on the actual liver using tracked instruments. After the first point was defined at the liver veins, a further point is defined at the falciform ligament, the gallbladder, and in the hilum of the liver. The navigation markers were fixed to the instruments, which are then calibrated and used for acquiring surface points on the liver. At the end of the registration process, the accuracy is tested on the liver surface. The target is chosen, and a second tracking marker is attached to the ablation needle, which is also calibrated, and then inserted into the abdomen with the help of the navigation system. The needle is inserted into the tumor under navigation and ultrasound guidance. Here you can see the laparoscopic view of the needle insertion, followed by the microwave ablation. In contrast to CT-guided ablation, the result cannot be validated immediately due to many artifacts in the peri- and post-interventional ultrasound, as demonstrated here. All patients are followed for 1 night postoperatively and receive antibiotics for 1 week to avoid an infection of the necrotic liver tissue. Follow-up imaging is performed 3 months after the treatment with Primovist MRI. Our targeting accuracy is high, with lateral and longitudinal arrows ranging between 1.6 and 3.2 mm in these 2 retrospective cohorts. Median time of a percutaneous intervention is 36 minutes and therefore not longer as a conventional freehand ablation. Complications are rare, mostly low-grade such as ascites, pleural effusion or microwave fever. With this I would like to conclude that stereotactic ablation is a safe treatment for liver tumors using accurate and precise needle positioning in a minimally invasive setting. It is an efficient treatment with a technical efficacy rate of 96% and a local recurrence rate of 6.3 to 23% at our institution, depending on the tumor entity. Stereotactic ablation offers a curative treatment approach, particularly for otherwise inoperable patients or lesions difficult or virtually impossible to target conventionally. In the future, we would like to define a possible extension of indications like biopsies and the ablative treatment of tumors in other organs such as the lungs, adrenal glands, or even the thyroid. We would also like to analyze the role of ablation for larger lesions, e.g. ablations with multiple parallel needles. And we would want to further develop the laparoscopic navigation techniques for ablation and also for resection. I would like to thank you for your attention, and I would like to invite you to the annual meeting of the European Computer-Assisted Liver Surgery Society, which will take place in Bern in October this year, also hosting a pre-conference hands-on stereotactic ablation workshop.